Okay, let's unpack this. Today, we're embarking on a deep dive into psychoactive substance use disorders.
Mhm.
Our source material is this really fascinating collection of excerpts from a textbook. It gives a pretty comprehensive look at how these conditions are defined, what they, truly entail, and how they're approached clinically. It's actually incredible how much our understanding and even the very language we use around substances and their impact has, well, profoundly evolved.
And our mission for this exploration really is to cut through some of the noise.
Yeah.
We want to clarify the key terminology, explore the diverse ways substances interact with the human body and mind, and understand the nuanced, often more compassionate approaches to treatment. Now, you'll definitely walk away from this with a solid, pretty thorough understanding, moving far beyond, common misconceptions. The real insight we want to provide is why a clear clinical understanding is so absolutely vital.
Exactly. You're going to gain a much clearer picture of what these disorders actually are, why the words we choose to describe them matter so deeply, and hopefully find some genuine aha moments that might just challenge what you thought you knew. So, one of the most striking things our sources immediately reveal is this fundamental shift in language. We're not just talking minor tweaks here. Terms like drug addiction and drug addict have actually been formally dropped from scientific use.
Mhm.
That's a huge step. What was the driving force behind that change?
Well, what's truly fascinating here is the why behind it. Our sources point directly to their derogatory connotation,
Right.
acknowledging the immense stigma these terms carry. So by moving away from them, the aim is really to reduce judgment and foster a more clinical, maybe more empathetic dialogue. The preferred current nomenclature now includes terms like drug abuse, drug dependence, harmful use, misuse, and the overarching term psychoactive substance use disorders.
Okay.
It's essentially a move towards recognizing these as health conditions, not, moral failings.
That makes sense.
And just for clarity, when we talk about a drug, the World Health Organization broadly defines it as any substance that, when taken into the living organism, may modify one or more of its functions.
Uh-huh.
A psychoactive drug, then, is specifically one capable of altering mental functioning. So the International Classification of Diseases, ICD-10, outlines 4 core patterns of these substance use disorders. First up, we have acute intoxication.
Okay.
Think of this as a transient state right after taking the substance, leading to disturbances in consciousness, cognition, perception, mood, or behavior. Now, while it's typically linked to high blood levels, our sources do note that even low doses can trigger intoxication in, say, sensitive individuals.
Ah, interesting.
The key here is that recovery is usually complete, unless there's some underlying tissue damage or complications occur. And these complications can range from, trauma to other medical issues, or even a specific condition for alcohol called pathological intoxication.
What's that exactly?
That's where even small amounts of alcohol can trigger really unusually severe aggression or behavioral changes in certain people.
Wow. Okay, so intoxication isn't just about being drunk or high, but a clinical state with potentially pretty serious consequences. What's the second pattern then?
The second is a withdrawal state. This is a cluster of symptoms, often very specific to the drug,
Right.
that develops when a person stops or significantly cuts back, usually after repeated or high-dose use. It's typically short-lived, maybe hours to a few days, and critically, these symptoms are often relieved by taking the substance again.
Okay.
Withdrawal states can range quite a bit, from uncomplicated to really severe, sometimes involving convulsions or delirium. Third, and this is really central to today's understanding, is dependence syndrome.
Mm-hmm.
And finally, there's harmful use, which we'll also distinguish carefully.
So understanding this shift in language isn't just like being politically correct. It's a really profound insight into how language shapes our empathy and, crucially, the effectiveness of treatment by reducing that stigma. It really helps you, as a learner, grasp the bigger picture, moving beyond those sort of outdated, stigmatizing terms. This linguistic evolution, it really lays the groundwork for a more precise understanding. And nowhere is that precision more vital than in defining what we now call dependence syndrome. Our sources explain this in a way that truly clarifies why it's far more than just, a habit. What exactly does dependence syndrome entail?
That's precisely it. Dependence syndrome, according to the ICD-10 criteria, is diagnosed when the use of a substance takes on a much higher priority for someone than other behaviors that used to hold significant value for them.
Right.
A definite diagnosis usually requires at least 3 of these 6 criteria to have been present at some point over the past year. First, a strong, almost overwhelming desire or compulsion to take the substance.
Okay.
Second, significant difficulties controlling the substance-taking behavior, whether that's starting to use, stopping it, or just managing the amount consumed. Third, experiencing a physiological withdrawal state, or, using the substance specifically to relieve or avoid those withdrawal symptoms.
Got it.
Fourth, clear evidence of tolerance. This means increased doses are needed to achieve the effects originally produced by smaller amounts.
Like the example you mentioned.
Exactly. Individuals dependent on alcohol or opiates might consume daily doses that would incapacitate or even be lethal to someone who is intolerant. It really shows how the body adapts. Fifth, there's a progressive neglect of alternative pleasures or interests because of the substance use. This often comes with an increased amount of time dedicated to getting the substance, using it, or recovering from its effects.
Right.
And sixth, persisting with use despite clear evidence of overtly harmful consequences, whether that's, say, liver damage from drinking, depressive states from heavy use, or cognitive impairment. The critical aspect here is that the individual is, or, could reasonably be expected to be, aware of the nature and extent of this harm. Our sources also describe something called a narrowing of personal repertoire as a characteristic feature.
What does that mean?
Well, for instance, someone with alcohol dependence might tend to drink in the exact same way on weekdays and weekends, regardless of, typical social constraints or opportunities. It becomes very rigid.
That's a really powerful picture of how all-consuming dependence can become. So how does harmful use fit in then? Is it sort of a stepping stone, or is it distinct from dependence syndrome?
Harmful use is indeed distinct from dependence, though both are serious concerns, obviously.
Okay.
It's characterized by continued drug use, despite the person being aware of negative medical and or social effects, or a pattern of use that's physically hazardous, like driving while intoxicated.
Right.
The key distinction our sources make is that harmful use is not diagnosed if a dependent syndrome is already present.
Ah, okay.
This clarifies that while both certainly warrant intervention, they represent different patterns of how someone engages with a substance.
That distinction is so important. Knowing these differences helps you understand the various ways substance use can impact someone's life and why interventions might need to be tailored, moving beyond that kind of one-size-fits-all approach. So we've redefined the language, we've honed in on the definitions, but what do these disorders actually look like in practice across the vast spectrum of substances? Let's turn our attention now to some of the major players in the world of psychoactive substances, because each has unique effects and challenges.
Yeah, absolutely. Our sources list 10 major categories of dependence-producing drugs. We're talking alcohol, opioids like opium and heroin, cannabinoids such as cannabis, cocaine, amphetamine, and other related stimulants, hallucinogens like LSD,
Okay.
sedatives and hypnotics, including barbiturates, inhalants, or volatile solvents, nicotine, and finally, other stimulants like caffeine.
Wow.
So each of these has its own profile of effects, its potential for dependence, and its own set of related complications.
That's a truly wide range. Let's maybe highlight a few examples that really showcase the diversity here and maybe some of the surprising facts our sources contain. What stands out to you about alcohol?
Well, with alcohol, again, revisiting the terminology, the term alcoholism has also been dropped, much like addiction, because of its derogatory nature.
Right.
Historically, people like Jelinek did try to classify alcohol dependence into different species based on use patterns, not necessarily severity, but how people drink.
Oh, interesting.
For instance, gamma alcoholism involved an inability to control drinking once started, whereas delta described an inability to abstain entirely, even if the amounts consumed were somewhat controlled. For practical screening, though, especially in general practice, the CAGE questionnaire is a really widely recognized and useful tool.
The CAGE questionnaire, yeah, it's so powerful in its simplicity. What insights does its structure reveal about the subtle ways problematic drinking often manifests?
Well, it directly addresses those often hidden signs. CAGE stands for. Have you ever felt you needed to cut down? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about it? And have you ever needed an eye-opener drink first thing in the morning?
Right.
A score of 2 or more often identifies problem drinkers, signaling, a need for further assessment. And our sources really highlight just how sensitive the body is to alcohol. Well, 80 mg% is a common legal driving limit in places like the UK.
Yeah.
Levels significantly higher can quickly become life-threatening. It underscores that narrow margin between impairment and real danger. And the severity of alcohol withdrawal can be really significant. Delirium tremens, DTs, is the most severe syndrome.
Right, I've heard of that.
It typically occurs about 2-4 days into abstinence in maybe 5% of heavy drinkers.
Mm.
DTs are characterized by vivid hallucinations, often visual but sometimes auditory too, marked autonomic disturbance like a racing heart, fever, and severe agitation.
Sounds terrifying.
It is serious. There's a 5–10% mortality rate, often due to complications like cardiovascular collapse. And long-term, chronic alcohol use can lead to conditions like Wernicke-Korsakoff syndrome.
Yes, you mentioned that briefly.
Right, it results from a severe thiamine, vitamin B1 deficiency. It leads to profound memory disturbances, confusion, and even confabulation, where people unconsciously fabricate memories to fill in the gaps.
That Wernicke-Korsakoff syndrome is just a stark, almost devastating reminder of alcohol's potential chronic impact. What about opioids? These seem to be constantly in the news globally.
They really are. Opioids, originally derived from the dried exudate of unripe poppy seed capsules, have been used for centuries. You hear about global routes like the Golden Triangle and Golden Crescent, historically significant in trafficking. Heroin, for example, is about twice as potent as morphine. And tolerance can build incredibly rapidly, sometimes to more than 100 times the initial effective dose.
Wow, 100 times.
Yeah. A key physical sign of opioid intoxication is often those pinpoint pupils.
Right.
Though, interestingly, in very severe intoxication due to lack of oxygen, pupils can actually dilate. Withdrawal symptoms, however, are quite diverse. They range from things like yawning and piloerection goosebumps to really severe anxiety, muscle cramps, nausea, that kind of thing.
And cannabis is another substance with just constant public discussion and evolving perceptions. What does our source say about dependence there? Is it real?
Well, our source notes that cannabis generally produces only a mild physical dependence. Some health professionals even question if there's true physical dependence in the same way as, say, opioids.
Okay.
However, it strongly emphasizes the presence of a strong psychological dependence.
The psychological aspect.
Exactly. Cannabis intoxication can also lead to some unique effects, like that curious splitting of consciousness, where the user might feel like they're observing their own intoxication from the outside, and even synesthesias like seeing music or hearing colors.
Right.
A debated complication of chronic use is amotivational syndrome, characterized by lethargy, apathy, a lack of ambition, though its direct causal link is still, under discussion scientifically.
Given that range, what about substances we encounter literally every day, like nicotine and caffeine? Are they truly psychoactive in the same sense?
Oh, absolutely. Both nicotine and caffeine, despite being legal and common, can definitely cause intoxication, dependence, tolerance, and withdrawal syndromes.
Really?
Yep. And here's a surprising fact from our sources. Smoking, specifically the hydrocarbons in tobacco smoke, not necessarily the nicotine itself, can significantly affect the metabolism of certain psychotropic drugs.
How so?
By inhibiting liver enzymes. So for instance, if someone on a drug like clozapine quits smoking, their blood levels of clozapine can shoot up maybe by as much as 50%, even if they start using nicotine replacement therapy like patches or gum.
Wow, so it's the smoke itself.
It's the hydrocarbons in the smoke, yes. Which means doctors need to be really careful with dosage adjustments when patients quit smoking.
Good to know. And caffeine, can you actually get intoxicated?
You can. Our sources define caffeineism, or caffeine intoxication, as typically occurring when someone consumes over 250 milligrams per day. That's roughly 2-3 brewed coffees for most people.
Okay.
And the symptoms can include restlessness, insomnia, maybe GI disturbance, a rapid heartbeat, anxiety, things many people might just brush off as stress.
That really does showcase the true diversity, doesn't it? From illegal drugs to the coffee we drink every morning. So with such a broad range of substances and effects, treatment approaches must be equally diverse and highly tailored, I assume.
Exactly. That's crucial.
So what does this all mean for actually helping individuals on their path to recovery?
Well, before any treatment even begins, there's a really crucial initial assessment phase.
Okay.
This involves ruling out any other underlying physical or psychiatric disorders that might mimic or complicate things. It also means assessing the individual's motivation for treatment, which is key, their social support system, and their overall personality characteristics. You need the full picture. Then the treatment itself is broadly divided into two main stages: detoxification, and then the ongoing treatment of dependence. Detoxification is always a first step. The focus here is on safely managing those withdrawal symptoms as the substance is removed from the body.
Makes sense.
For alcohol detox, the drugs of choice are typically benzodiazepines like chlordiazepoxide or diazepam.
Okay.
These are usually given in a steadily decreasing dose over several days, sometimes up to 10 days for more severe withdrawal, to manage it safely and prevent things like seizures. And crucially, especially if other supportive fluids like 5% dextrose are being given intravenously. Vitamin B1, thiamine, must be administered via injection, often IV, rather than just orally.
Why is that so important?
It's absolutely vital to prevent severe neurological complications like that Wernicke-Korsakoff syndrome we discussed from developing or getting worse. Giving carbohydrates without adequate thiamine can actually precipitate it.
Wow, okay. Critical detail. And for opioid detox, is it a similar approach with benzodiazepines, or are there different strategies?
For opioids, there are indeed different strategies.
Yeah.
One common approach involves using substitution drugs, like methadone.
Right, I've heard of methadone programs.
Yeah. It's technically less addicting than, say, heroin, and it has a milder, longer-lasting withdrawal syndrome. Now, critics do argue it's just replacing one dependence with another, but it can significantly reduce illicit IV drug use and the associated risks, like crime and infection. Another approach uses clonidine. This isn't an opioid itself, but it helps manage many of the withdrawal symptoms by calming down that sort of overactive nervous system response you get during opioid cessation.
Okay.
And a third method, sometimes used for rapid detox, combines naltrexone with clonidine. Naltrexone is an opioid antagonist, meaning it blocks opioid receptors. Giving it actually precipitates withdrawal symptoms quite quickly.
Oof, sounds rough.
It can be, but the clonidine is given simultaneously to help manage those symptoms. Then, once detox is complete, naltrexone continues to be used because it blocks the pleasurable effects if the individual tries to use opioids again, acting as a deterrent.
So quite a few options depending on the situation. Okay, so once someone has navigated that immediate, often pretty grueling withdrawal phase, what comes next? What are the modern ethical approaches to treating the dependence itself and supporting long-term recovery?
Right. After detoxification, the goal shifts decisively to preventing relapse and supporting that long-term recovery. And it's really important to stress, as our sources do, that aversion therapy, which historically used methods like electric shocks or nausea-inducing drugs, is now widely considered unethical and is rarely used in most modern settings.
Good to hear.
Instead, contemporary approaches focus on a multimodal strategy. Psychotherapy, both individual and group formats, is incredibly important. This involves educating the patient about the risks, encouraging them to take personal responsibility for change, and offering practical lifestyle modifications. Techniques like cognitive behavioral therapy, CBT, and motivational enhancement therapy are often central here. Group therapy also plays a really significant role. Our sources highlight the impact of voluntary self-help groups like Alcoholics Anonymous, AA, which have, a vast membership worldwide. While their approach is not professional and partly spiritual, many patients benefit immensely from the peer support and the shared experience found in those group meetings. Then there are specific deterrent agents. A well-known one for alcohol is disulfiram, which was actually discovered back in the 1930s.
How does that one work?
Its mechanism is quite distinct. When someone taking disulfiram ingests even a small amount of alcohol, their body can't properly break down a toxic byproduct called acetaldehyde.
Uh-oh.
Yeah, this leads to its accumulation to the blood, causing a really severe reaction called the disulfiram ethanol reaction, or DER.
What does that feel like?
It's characterized by intense flushing, a rapid heartbeat, severe anxiety, nausea, vomiting, and sometimes a profound sense of impending doom. It can actually be life-threatening in some cases, potentially leading to shock or even a heart attack.
Wow, that's serious.
It is. Because of that, treatment with disulfiram is often initiated carefully, sometimes in an inpatient setting, occasionally even with a tiny challenge test under medical supervision to demonstrate the effects. And there are important contraindications like pregnancy or severe heart or liver disease.
Okay. Any other types of medication?
Yes, finally, there are anti-craving agents. Medications like acamprosate and naltrexone, which we mentioned for opioid detox too, but it also works for alcohol craving.
Right.
And even some SSRIs like fluoxetine can work to reduce that intense desire or craving for the substance, making it easier to maintain abstinence. But ultimately, our sources really underscore that psychosocial rehabilitation is an absolutely integral part of this whole multimodal treatment picture.
Why is that so critical?
Because relapse rates can be high without it. It's crucial for addressing both the occupational and social aspects of recovery, helping individuals rebuild their lives, find new coping mechanisms, and develop healthier social networks. It's about the whole person, not just stopping the substance use.
We've truly covered an incredible breadth today, haven't we? From redefining these complex disorders and challenging old stigmas to understanding the diverse effects of so many substances and exploring these multifaceted approaches to treatment,
Mhm.
it really highlights the complexity and the sheer importance of a nuanced understanding that goes way beyond surface level assumptions.
And if we connect this back to the bigger picture,
Hmm.
moving away from those derogatory labels like addict towards clinical terms like substance use disorders,
Hmm.
it isn't just about being politically correct, as you said earlier.
Right.
It's genuinely about opening the door to more effective, more compassionate, and evidence-based treatment. It's about recognizing these as legitimate health conditions that deserve the full attention and resources of medical science and society.
So, considering everything we've explored today, what does it really mean for us as individuals and maybe as a society to fully embrace this clinical understanding? How might this shift in perspective truly change the way we interact with and support those affected by these challenging conditions? And perhaps, what role do we each play in fostering that empathy and understanding? What stands out to you from this deep dive? We certainly hope it's given you a deeper, more informed perspective on a really complex topic.